Hi everybody. This little clip is designed to help prescribers know what to prescribe in the event that you find yourself looking after somebody who is with advanced illness or at the end of their life and needing injectable medicines. So the first 3 slides look at standard starts. This slide talks you through what I would expect you to prescribe for somebody when you're asked to supply just in case medication. There's a few things to note on this example. The first thing is this is all about people who are opioid naive as a standard start. Now, this is the guidance that probably every day in the hospice we use. Most people that we look after just need a simple standard start as they move from being able to manage oral medication to being at risk of not being able to manage oral medication. What we do is we ask the prescriber, or we prescribe them when they're in the hospice, something for pain, something for nausea, something for agitation, distress, and something for respiratory secretions, because pain and breathlessness, nausea, agitation, and respiratory secretions are the commonest symptoms suffered by people at the end of their life. For the pain and breathlessness, the drug you'll need is, as a standard start, morphine sulfate at a dose of 2.5 to 5 milligrams PRN, maximum frequency 1 hourly, maximum 24-hour, could be anything between 6 times 2.5, 15, to 6 times 5, 30. In this case, I put 30, but either of those are completely reasonable. And what you would be authorising if you were also asked to authorise a syringe pump would be dose range 10 to 20. We would ask you to supply in the first instance for people who might develop these problems and are at risk of developing these problems, 10 ampules of 10 milligram per 1 ml. For nausea and vomiting, our standard antiemetic for just in case prescribing is levomepromazine. I've given you a sensible dose range, 6.25 to 12.5 milligrams. Sensible maximum, I've actually chosen 25 milligrams in 24 hours. And for a syringe pump, levomepromazine, a sensible range. Remember that the maximum here is separate to what's in the syringe pump. So you can give up to 6.25 times 4 for this person in 24 hours. A sensible supply, 10 ampules of, oh, there's a mistake there, 25 milligrams in 1 milliamps. And then for midazolam, 2.5 to 5 milligrams is the standard start and range for PRN injectables. You can give them up to hourly, and you can give a max of anything between 15 and 30 milligrams in 24 hours. In this case, I put 30 milligrams. I've also written what you would write as a standard range syringe pump start, and I've asked for 10 ampules to be prescribed. 10 milligram per 2 ml strength is the strength. And then the last one, anti-secretory, the one we use in this region is glycopyrronium. 200 micrograms to 300 micrograms would be a sensible range for PRNs. You can give this drug 4 hourly, same as antiemetic, or a maximum of 1.2 milligrams in 24 hours. I've also given a sensible range for a standard start syringe pump, and I've asked the prescriber to supply 10 ampules. So this is what I would call a standard start prescription, 10 ampules of all on the right-hand side, with apologies for the typo there for levomepromazine, should say 25 milligrams per 1 ml. Now, this will suffice for almost all the patients you will ever look after who are not on opioids, but who are in danger of needing some opioid in the last few days of life. You will look after people who are frail, elderly, with multi-comorbidities, and you may be concerned about the dose size and the weight of the medicines that I've just shown you in the standard start. So for frailty, if you have a patient who is frail, notice a slight change in what I would suggest in the prescription. So a smaller dose of morphine sulfate for pain or breathlessness, but still the ability to give up to 2.5 milligrams. A different antiemetic, a lighter one that's less potentially sedating. We've chosen haloperidol as a sensible antiemetic for people who are frail. And similarly, you'll see a reduction in the midazolam, so it's not as heavy for the frail patient. But again, you can still give them often, and you can still give them up to 30 milligrams in 24 hours, because you just simply don't know how much your patient will need. And for each of the meds suggested, we're asking for 10 ampules of each, because we don't want you to be breaking into pack sizes at the dispensing stage. So the prescriber needs to be prescribing a little pack for each. Finally, what to prescribe for people who you know have severe renal failure. Now, it's important to stress that you'd only be using this guidance if you knew that your patient had a very poor EGFR, less than 30, or if they had a clinical history of severe renal failure. If you don't know that, then you would just go for the standard start. But for people who are known to have severe renal dysfunction, the change is that the drug that we ask for pain or breathlessness is oxycodone instead, small doses, and the drug for the syringe pump would be alfentanil because it is not renally excreted. And again, the doses are small. And the supply that we ask for, we've written the amp size, and the quantity is 10 ampules. Amp size, quantity 10 ampules. Haloperidol is the antiemetic of choice for people with severe renal dysfunction. And again, we've supplied a dose range for the PRNs and a dose range for the subcut pump, and what sensible prescription to supply. With midazolam, the doses are small, just as they would have been for somebody who was frail, and we ask a sensible prescription to supply. And with glycopronium, actually, the dose remains the same for glycopronium as it would be for a standard patient. And again, we've suggested 10 ampules, and we've given you the ampule size. So that enables you to write a sensible amount of drugs for the house when you're prescribing for an authorization. It's hard to know what to prescribe for people with a range of symptoms. So this section just looks at the resources you can turn to. So locally, we have a really helpful resource in a NELVT publication, which was last updated at the end of 2020, and I'll go through that in some detail. You could also look at Palliative Adult Network guidelines, which are available online, and give the focus, it goes beyond very end-of-life care and injectable medications to provide a really helpful resource for oral as well as subcut medications, and for much broader symptom control. It would be my go-to for any GP or district nurse wanting to help patients with symptom control issues as a first start. And then, of course, there is your local specialist palliative care team. I've written our number, the Redbridge number, but there's also in Inner East London, the Margaret Centre in Whipps Cross, and St Joseph's Hospice in Hackney. Each borough has an end-of-life care facilitator. Locally, these are a fantastic source of advice and support. And the telephone number for the Outer East London end-of-life care facilitator, as well as the Essex end-of-life care facilitators, are all written in the NELVT publication. And then at times your patient may be coming from hospital to home, or may have recently been in hospital. The hospital specialist palliative care teams are also extremely useful. So I'm just going to talk about what's in the NELVT guidance, because it's a very rich source of advice and support for people at very end of life in terms of injectable medication. So as well as giving details of telephone numbers of specialist palliative care, telephone number of the borough end-of-life care facilitator, detail about extended hours, pharmacies, and what drugs they stock if you're on the search for somewhere to dispense the drugs you need for your patient. They also give clinical guidance. So I'm just going to show you a couple of examples of the 5 flow charts which take you through pain, nausea and vomiting, breathlessness, restlessness, and retained secretions, the 5 common symptoms at end of life. Not every patient has those symptoms, but what you want to be sure about is that you have provided injectable medication in case they should get any of those symptoms. So, for example, the pain flow chart in the NELF guidance asks the first question, is your patient on opioids? If they're not on opioids, then the guidance is very much as I just outlined on the previous slides. If they're already taking a weak opioid, the guidance actually is pretty similar, not that different from opioid naive. If they're already taking strong opioids, then it gets a bit more complicated. You need to have a knowledge about the relationship between the oral opioid and injectable opioid to make sure that you actually prescribe and authorize enough opioid for the patient not to suffer from inability to swallow their regular dose. You need to be sure that you're matching what they were needing for comfort with what they need now that they can't manage oral medication anymore. And there's a number of sort of highlights underneath about what to do if they're on co-opioids or on non-opioid pain relief and various other scenarios, including renal failure. So that flow chart is complex, but it's also rich in terms of the advice it gives. Just to signpost you through the NELF guidance, the guidance is quite thick, so you need to know where to look. And the flowcharts are all at quite some of the early pages of the guidance. So, for example, this one is on page 6, but the guidance for the other symptom control issues that I've mentioned just then follow page 7, 8, 9, and 10. I'll just quickly flag up the flowchart for nausea and vomiting because that's the other complex flowchart. So again, the flowchart gives what to do if they haven't got nausea and vomiting, but just in case they might do, what would be your standard PRN to prescribe? If they are not on antiemetics, but actually they've now developed nausea, if nausea is present and they're not on, or if they are on and they've developed nausea. So you can see that the flowchart is quite complex. And you'd have to sort of sit and look at it quite carefully to find out what you ought to do now, what you ought to prescribe. But actually, if you could start with what your patient is suffering, it will help to work you through it. And there's some specific examples underneath to help you so that if your patient, for example, was well controlled on oral metoclopramide, you know which dose to put PRN injectable and in the syringe pump, if they're on haloperidol similarly, and so on. So a complex flowchart, but very, very useful. The other 3 flowcharts for breathlessness, restlessness, and retained secretions are very simple. And take a lot less looking at, so I haven't shown them here, but do look at the resource. And the bottom line is, if the PAN guidance, if the NELF support is difficult to understand, or if you don't quite know what to do, or if you haven't got the time to look into those sources and you just need some help, just contact your local palliative care team, who would be happy to help to guide you as to what to authorise or what to prescribe. If your patient is has any other features other than standard starts, because it can be complicated, they will be happy to help. And that's the end of this clip.